Escalation of a care is a very critical concept where the bilirubin is coming at or close to the exchange level. So it refers to the intensive care that the babies with elevated or rapidly rising bilirubin concentration need to prevent the need for an exchange transfusion and possibly to prevent kernicterus. Escalation of care threshold is 2 mg per deciliter below the exchange transfusion threshold. The exchange transfusion threshold in the first 24 hours is in a dotted line. So if it is not really too high levels, you can monitor it, especially if there is no risk factor, but obviously it's better to stick with the guideline and follow the threshold. The direct reacting or conjugated bilirubin value should not be subtracted, similar to the treatment decisions for phototherapy when you are determining treatment. Initiating escalation of care is a medical emergency because exchange transfusion is designed to prevent brain injury. So if you're reaching as close to that, you're not far from a brain injury situation. Escalation of care starts from the time the infant's TSB result first mandates starting escalation and ends with the TSB is below the escalation of care threshold. So this is a medico-legal risk, so please document clearly all the times involved. These infants are optimally managed in an NICU, though if you have a drum phototherapy that is delivered in the ward with good supervision, you can monitor at least for the first level after you start the phototherapy if it is the first level that you are doing. Urgent transfer to the NICU that can perform an exchange transfusion is important. If you are in a hospital where you manage such babies in the ward with drum, the NICU should be aware and the preparation for exchange should be ongoing, even if you keep the baby in the ward for the next 4 hours when you are awaiting the bilirubin levels 2 to 4 hours. Intensive phototherapy and intravenous hydration should be initiated and continued when it's approaching the exchange level as well. So we can either start it immediately or after the first 2-hour repeat. If it is coming down, you may not need intravenous hydration. If it's going up, you need intravenous hydration. So that's an individualized practice that you would consider. But again, don't take any risk in these babies because they are close to the exchange level. And the higher the level of bilirubin, the higher the risk of neurotoxicity. That's why you can be a little bit flexible, in my view, in the first 24 hours or so, because the lines are not that defined and many more babies would have, because the levels are quite low. And it's very unlikely bilirubin neurotoxicity happens at that level. It's more a trend that if it continues, these babies would cross the potential, but they're far below the level when the bilirubin toxicity would happen. So I hope this point is clear. Don't be confused by it. It's just that you have a little more leeway in the first 24 hours compared to the rest of the time when the bilirubin is really quite high. For infants requiring escalation of care, blood should be sent stat for total and direct reacting serum bilirubin, complete blood count, serum albumin to put them in the risk group, and rest of the serum chemistries and type and cross match for the exchange preparation. Infants requiring escalation of care should receive IV hydration and emergent intensive phototherapy, and neonatologists should be consulted and urgent transfer to a unit with an ICU if you don't have that facility yourself. The TSB should be measured at least every 2 hours. So this is important to note because they want it every 2 hours from the start of the escalation until the escalation of care ends. So as we defined here, so it ends when the TSB is below the escalation of care threshold. So the bilirubin has to come 2 blocks below the exchange transfusion cutoff for that age. So this is a flow chart indicating this. So the starting point is when the TSB exceeds escalation of care level, and is the baby at appropriate location. If they are not, contact the NICU, arrange for transfer. In addition, start intensive phototherapy and peroral or IV hydration during the transfer. If they are already in a good unit who can do the exchange, then you send the stat labs as we discussed, notify the blood bank, measure the bilirubin at least every 2 hours, and intensive phototherapy and peroral or IV hydration and immunoglobulin therapy and bilirubin albumin measurement options can be considered. Acute bilirubin encephalopathy or latest TSB is above, then urgent exchange transfusion should be done. If the baby doesn't meet the exchange level, you can continue intensive phototherapy and hydration and measure every 2 hours till you de-escalate. In terms of hemolysis, you also have end-tidal carbon monoxide measurements. Most of the units do not have that, and that's an indirect marker for hemolysis.